A 57-year-old Miss X came from Katpadi with complaints of rash all over the body for 3 months, difficulty in climbing stairs for 3 months, difficulty in lifting arms above head for 3 months, and difficulty in swallowing for 3 months.
Just hold that for a second. You'll go back. What's your diagnosis? I'll give my gift to you. You give me the first diagnosis. Okay, consultants.
Cutaneous involvement and
Dermatomyositis. Correct? Huh? Go ahead. Yeah, actually, no. Go on.
She was apparently normal before 3 months. Then she developed a rash, which was insidious in onset, progressive in nature, started from neck, then spread to chest, abdomen, axle, and thigh, which was scaling, not associated with itching. She had difficulty in combing hair and bathing, no difficulty in mixing food. She had difficulty in climbing upstairs and squatting to standing, no history of slipping of slippers. She had difficulty in turning from one side to another side. She had difficulty in swallowing of food which was solids more than liquids. Past history, she was evaluated outside for the same complaints and was treated with oral steroids. She is a known hypertensive for 5 years and on regular medication with no significance of personal or menstrual history. And this image was taken after the consent from the patient and relatives, and it shows the periorbital edema and the scaling non-itchy rash over the thigh. On examination, head to toe, shows the periorbital edema, inflammatory edema of the face, and photosensitive papiloderma, and with V sign of a Schall sign in thorax, and Holzer sign was present. On vitals, patient's pulse rate was 80 per minute and regular, blood pressure was 120 per 80 mmHg, and saturation was on room air maintained. And the patient was conscious oriented. On central nervous examination, his higher mental function was normal, gag reflex was sluggish, and pulling of saliva was noted. Other cranial nerve examination was normal, and bulk and tone was also normal. The power of shoulder joint in both limb was 1/5 and elbow joint was 3/5. Wrist and hand grip was normal. Power of hip joint was 1/5, and with knee ankle joint power was 5/5. All reflexes are normal, and all sensations are able to perceive. No cerebral or meningeal signs, and other systemic examination was also normal. It's already diagnosis for.
Sorry, I disrupted your presentation. I know.
So the syndrome.
You have a better system like that, but you should introduce it earlier. After each slide, you put it after history and after examination.
Okay. So our patient was presented with syndrome complex of bilateral symmetrical proximal muscle involvement with normal reflex and sensations associated with skin lesions. Clinical localization was done was myopathy. So our probable difference was considered was inflammatory myopathies of dermatomyositis, polymyositis, inclusion body myositis, and metabolic myopathies. So our initial investigations was the HB and total counts was normal, and minimal elevation of SGOT and SGPT with metabolic parameters was normal with normal, and TSH cortisol also normal. So metabolic causes was ruled out, and the CPK and LDH was high associated with ANA was 2+ and speckled, and myositis profile baseline was positive for SA3 positive. So our clinical diagnosis considered was dermatomyositis. On our patient, she developed a new onset of fever associated with the difficulty in swallowing. So we can she developed aspiration pneumonia, and she was started on injection present tazobactam, and for underlying dermatomyositis, the steroid plan was withheld because of the aspiration pneumonia. Meanwhile, she developed a sudden onset of breathlessness, and the ECG and showed the STEMI. So with after that, the cardiology consult was getting, she received the rolling dose of antiplatelets and statins and started on inotropes. In spite of all measures, she is compared to refractory cardiogenic shock. And So we mainly focus on the complications of the dermatomyositis of heart disease, respiratory disease,
What
malignancy.
happened to the patient, sorry?
She's developed semis. And gastrointestinal tract complications. Some antibodies are specifically associated with some complications. Anti-Jo are mainly associated with interstitial lung disease and mechanical hands, and anti-MA2 antibodies are mainly associated with acute onset of disease, and anti-SRP mainly associated with severe myositis, and anti-MDA5 is mainly associated with progressive interstitial lung disease and severe cutaneous involvements, and anti-TAF gamma are also associated with malignancy. Heart disease, cardiac involvement was there. Most common cause of death in polymyositis, mostly 10 to 20% of population. It is a higher 60 times of higher in a female compared to male. It is a this is a retrospective cohort study, shows the outcome of 2 ways. Have clinically manifest heart involvements are mostly associated with congestive heart failure of 3 to 40% and left ventricular diastolic versions of 12 to 42% in dermatomyositis and polymyositis patients, and subclinical involvement mainly in with the ECG abnormalities only. This is another prospective cohort study, shows the acute coronary syndrome in dermatomyositis and polymyositis patients, and it also shows the overall risk of increasing the acute coronary syndrome in dermatomyositis patients. Interstitial lung disease is one of the most common and severely potential life-threatening condition associated with dermatomyositis. This is another one recently released of a retrospective cohort study done in Japan. It was followed over the 8 years with increase and outcome shows the increased incidence of interstitial lung disease in dermatomyositis patients. The first graph was dermatomyositis patients age group with the incidence per 100%. The age increasing, the incidence of the interstitial lung disease also increasing, and in the second graph shows the polymyositis with incidence of interstitial lung disease is most commonly stagnant over the periods. It's also another retrospective cohort study. Most common malignancy associated with dermatomyositis of male and female over the 202 people are studied. In this, 135 people are non-malignant and 65 people are malignancy considered. In 65, most often the male malignancy are considered. Males are most commonly associated with lung cancer and esophageal cancer, and females are most commonly associated with thyroid and breast cancers and cervical cancer. Gastrointestinal complication most commonly associated with dermatomyositis are dysphagia followed by gastrointestinal perforation. Other problems are associated with abdominal pain, vomiting, and diarrhea. So my take home message was how to approach and mainly to complications of myositis.
Questions from
In
the
this
audience?
case, the CPK was only 400 to 300. Was it partially treated outside or?
So she already started on steroids and hydroxychloroquine outside also. So she had.
And what is particular about SAE antibody is positive?
Yes.
What is particular about that antibody? Because they all have different prognosis or different associations with malignancy or ILD. Is anything in particular about SAE positivity?
Say it's highly associated with dysphagia, which is not very common in dermatomyositis patients. There are striated muscles of swallowing, which is affected in this patient, which we did not expect. Recently, she got the aspiration pneumonia, and that's the reason she was sick. The reason she was not treated immediately. In the meantime, she got an admit, which is also a high chance complication in this patient, which basically she suffered. That's what we wanted to put forward, saying that complications of dermatomyositis must be thought of, and dysphagia is also a specific because that was normal when we did ladies following, she had aspiration. That was normal. So that is nothing which
I have a question related to that. You said that the patient's dysphagia was more solids than liquids. Is that expected with the patient who has got muscle weakness? When do you classically say it's solids more than liquids?
Malignancy.
Malignancy.
Like in structural lesion, malignancy strictures, extraluminal obstructions. So is it compatible with the clinical diagnosis? Solids more than liquids? So as I was, this question was going when I did the search. So that is classified for esophageal causes of dysphagia. Okay, so esophageal dysmotility causes both solids and liquids. Esophageal structural lesions like masses cause solids more than liquids. But this is an oropharyngeal cause of dysphagia. There, in whatever may be the cause, apparently solids are more than liquids. And even in SA antibodies, the dysphagia is classically more to solids than liquids. New information from me. I have a comment for your differential diagnosis. This is a patient who has got features suggestive of myopathy and a skin rash. Okay, so I don't think body myositis and inclusion body myositis should feature there. Inclusion body myositis classically presents with a distally predominant streak, so that should not feature here at all. And your metabolic process also, unless it is associated with the rash, which you should be able to explain, like Cushing syndrome maybe, but it should not have featured in your differential diagnosis. How long was the history for?
It's 3 months only.
Actually,